Sorry, I'm going to have to run through that again. Thanks for joining me, guys. I'm glad it's the same group as last week. I'm going to follow up on what we did last week. I'm going to have to take this off, sorry. And talk a bit about the nursing framework we talked about, which was the laws, the policies, the procedures, the standards and the regulations that we abide by as nurses. And within that framework, I'm mainly going to focus on the National Safety and Quality Health Service standards. So that's the 8 standards we talked about that that kind of override everything we do. And I'm going to try and link that to the documentation that we use in emergency. And then we'll do a bit of a scenario where I want you to fill out one of the pages in our main triage document, and we're going to sort of kind of go through it bit by bit and try and link it back to the standards. And then I'll ask you to do an evaluation at the end if you don't mind. Now, have any of you been to the Education Centre before? Of course you have. So in the case of a fire alarm, just make your way out that door and turn right the way you came. If there's no fire warden out there to see, just head for the stairs. Follow the exit signs, obviously don't take the lift. Okay, so again, the nursing framework that I was talking about last week. So when you think about all of those things, it's kind of overwhelming to think, well, I have to know so much stuff to practice safely, and how do I know that I'm doing it properly? And when you look at the 8 standards, I think it's kind of simplifies it if you just think about the bottom 6 as the ones that we actually have to deal with when we're nursing on the floor, when we're actually looking after patients. And the top 2 are sort of the boring ones, I'd say, that are controlled by people that don't actually work clinically usually. They are people that work in offices and they do all our research, and they work out the best practice by gathering our data, obviously crunching our numbers, getting best practice from all over the world, and working out what they want us to do. And from that information, with the clinical governance especially, they try and look at the culture of an organisation and the safety and quality systems that keep patients safe and lead to better outcomes. And that can be, if they write the policies and procedures, risk management, etc. And they also look at how we partner with consumers, getting them involved in their care. It's things like including them in the handover and thinking about their health literacy, so not using a lot of jargon around patients and trying to help them to understand their own health. So when, as I said, you can get some overwhelmed with all of this because it's hard to try and think of, how can I not make a mistake? How can I know all this stuff so that I never make a mistake? And it is quite frightening. But the good thing is these safety and quality systems that people create for us, they all filter down basically into our paperwork. So if you are filling out your documentation properly, you are meeting most of these standards. So it's all about documentation and doing it well. And as we go through this form, I'll show you how it links to the standards. All right, so I want to do a scenario. So this is me, I'm the patient. Oh, it's going to be a hospital gown. Put that on. I'm going to go through a few steps. I'm good enough. We're going to go through a few steps. I'm going to follow up from that scenario we did the other day. So your patient, you're working in resus, and your patient has come in, and remember I said the other day, the only information you'll probably have is what's on the front of that triage form. It's going to have maybe 3 lines. You've got no access to their records really, because it's too hard to look up, wasn't it? This will all be, just you pretend that's all been filled in, okay? So you've come in, you've done your obs on this patient, you've done your A to E, you've done the focused assessment that we talked about the other day, and now we're going to look at the inside page. So I'm going to open up this page here, and we're going to go through this step by step. And just close the rest of it up. So I just want this inside page, get that page open. So if you just fold it up so you just got access to that one. So first of all, I want to talk to you about the patient identification. So you would have, this is the one thing that you wouldn't be doing in this order. You would have done that when you first walked in and introduced yourself to the patient. So I'd like you to pretend, like, be in pairs. So 1, 2, yep, and Denise, one you can go with. Thank you. So I want you to identify this patient and put their name band on in pairs. Okay, so who wants to be the patient? So the first person needs, so you be the patient, and you be the patient, and Denise will be the patient. So you walk up to that, hi, I'm a nurse.
Hi, I'm Charlie. To have your full name and then
Tell me your full name.
So using 3 identifiers. Yeah. So it's quite good here because the clerks will organise their address and make sure it's the right address. So with our so actually put the name band on. Put the name band on. Yeah. So you put one on each other.
Denise Taylor doesn't exist
You are all now. Okay. Can you put one on Daniel as well?
Oh, fine. I'm just gonna open.
Have you not got one?
I'll put it
I am Helen.
So you need to know who you are.
And Darlene Moore.
Hi, I'm Denise. I'm just going to put a name band on you. Just to identify you properly. Can you tell me what your full name and your birthday?
Hello, Frank.
I think that's,
Just call
yeah,
it.
that's it.
And your address?
Oh, wait, not that. That's it.
Yeah.
And your emergency somewhere? In case you wander?
Thank you.
Right, so really our name bands don't have the address on, but you should use 3 identifiers when you're the first person identifying them. So the address will be on their labels. So they should come in with their labels and med chart and their triage form and their name band. So you would identify them with 3 identifiers. So you're the first person doing it. Okay, so you've done that. So now where do you document that? Okay, so can you fill that in? And what else have you noticed about that name band? It's red. So what have you asked your patient? Yeah, and what else have you asked them about their allergies?
what their reaction is to it. That's what I want to know, the contributions to their course.
Yeah, so it's not enough just asking what they're allergic to. So what bit of paperwork are we going to fill in now? Don't worry about that front page, just assume the front page has been done. What are you going to fill in about it? Yeah, the med chart, yeah. So I want you to write their allergies on there.
Are we allowed to write that?
Yeah, it's all to be shredded at there.
No, but
Oh,
in
I don't know, are students allowed to? Yeah, as long as you get a countersign.
Okay.
Yeah, get a council on them.
And some of this you might think, well, am I allowed to do it as a student? Well, we're theoretically your nurses for the purposes of this.
Yeah.
Alright, so fill in that. So I'm allergic to penicillin, I'm the patient, I'm allergic to penicillin. What else do you want to ask me?
What's your reaction?
Well, when I was a child, I had, my mum said I had a rash when I had penicillin, so I've just never tried it since. So you would also write rash as a child, so I always write that, because then the doctors know they may or may not still have an allergy to it. But it's just, that bit of detail is one of those, like, it's critical information that we were talking about the other day, it's important for the doctor to know. Now have you, I just want to see how you're doing there. So what else have you done on that? What else can you do on that allergy section? because this is where you become non-compliant with your standards by not following up and following it through. Alright, so we've all completed that, done that completely. Now there's one more thing we can do about allergies, one more thing that will trigger a warning for people. Do you know what that is? Alright, so we've got stickers. Chuck stickers on, pass them around.
Oh, sorry.
That's your one and a contribution for today.
Yeah. It's hard though, isn't it? Alright, so you've got one on the back. So whose back of the chart looks like that? Yeah, and is there something missing from the back of the chart? Yeah. It's meaningless if it doesn't have their name on it. And it drives me nuts because you see this a lot, you know. There's no name sticker on the back, and sometimes doctors will come and chart a heap of medications on the back, and there's no sticker on it, so always put the stickers on. Don't worry about that form, don't worry about that one. Well, if you were triaging, and actually, you know, you can actually put one on, where is that? Is there one here? Is there one on this form? No. But if there was a spot, put a sticker on it.
It's on the inside.
Yeah, yeah. So I don't want to go right into those at the moment, I just want to like stick with this, because we just don't have time to go into that. Okay, so by doing that, so you've now identified the patient correctly, you've done your 3-point identification, you're communicating critical information by taking that information about the allergies, and by stickering and everything like that, you're communicating that to other health professionals that might see that patient, and you've documented the information by writing it down. So you're conforming with the community for safe, communicating for safety standard and the medication safety standard just by doing those things. And you get really quick at it, you know, you just like whip through that, that'll take you a minute, 2 minutes to do that. Alright, so the next thing is, what is the next thing, Helen? So this is me, so I've come in with chest pain, I've come in as an ATS 2 hours ago, and I had an episode of shortness of breath and diaphoresis lasting 10 minutes, so it sounds really kind of car gap related. So, go on with that. Medication safety, so the next thing is, so you have, sorry, I lost my train there. So you've done your A to E, I'm actually stable now, I haven't got any pain anymore, there's nothing drastic that needs doing, all my obs are fine. You've done a focused assessment, talked about my pain, you've got my history and everything like that. So we're going to go back, we're happy our patient is safe for now, so we're going to go back to this form. So first of all, body diagram on the left, on the top left, what can you fill out there? If you look at the list of options down there,
Ask you.
well, I came in with pain, didn't I? So yeah, you can ask me. Like if I was a car accident, there'd be lots of things to ask me, wouldn't I? There'd be lots of things to fill out on that diagram, but really it's going to be quite simple, just marking that diagram with.
I missed it. Sorry.
Okay, that's right. So see the list of, so yes,
Oh,
that's
what's
the
your
hard
situation?
thing. Oh, chest pain.
Okay.
Yeah, that's the hard thing because I don't know what you guys know. So chest pain or pain is a P, and then you just have to put a P in that location. And you can get really, you know, obviously some people have lots of things going on. Oldies can have like leg ulcers and cellulitis here and there, and as well as like skin tears, so that can get quite complicated. This is quite a simple one. Okay, so in the meantime, while you're doing all this, the doctor's come in and popped in a cannula. So he's walked off without taking any record of it. So where do we record that? Yep, so what you can do the date and the time. Let's put a 20 gauge in my left ACF. And it's not an emergency insertion really, I don't know with that one, but no, the person's stable.
It depends whether it was done under ANTT or not. If ANTT is compromised, that's when they have to take yes.
Oh, yeah, okay, yeah. That's when they put that red dot on, isn't it? Yeah. Okay, and you can, because you didn't do it, don't sign it, but I would write doctor. And even if you don't know the doctor, just write doctor. Because it's always going to be the doctor, the treating doctor that does it, so they'll be able to find that person later. So filling about that bit of information, we're conforming to the preventing and controlling infection standards, because infections from cannulas is a huge issue, and it's really embarrassing, I think, if we send a patient to the ward and they haven't even got a document of when that cannula went in. So we don't have to do the whole big PVIS form. We should after they're here for a certain amount of time, but as long as it's documented when it went in, that could go off to another hospital like 24 hours later. And it really should be documented. It's part of our responsibility, all of us, to document when that goes in. All right, now this is another thing that nobody does. Now this goes back to actual policies, and we have a patient property management policy at Fiona Stanley, and a lot of property goes missing, and we have to replace, we have to compensate people, and we spend thousands of dollars compensating people for lost phones and whatnot. And we can avoid that by documenting their property when they come in, and you can do that also really quickly. And I don't know if the nurses you're working with, some do, some don't, but you can do that really quickly. So I would walk up and say, Emma, I just want to document any property that you've got on you, just in case anything goes missing. We've got a record of it being here when you came in, and then they think, oh, it's good for me because it covers my. It covers me, but it's not just actually covering the hospital. It's both, but So do you have a phone with you?
Yes.
Can I please see that phone? Never just trust them as they use it on the phone. It might be in their bag, although it's not actually there. They've left it at home. They think they've got it. Yeah, so that's an iPhone. Do you know what model it is?
No, couldn't tell.
Okay, so you just say black. Sometimes they do, sometimes they don't. If you can get more detail, do it. So then you would write black iPhone and the mobile phone one. Yes. Black iPhone, and I can't remember what else we've got there. Any glasses? Yes, you've got your glasses on, so yes, yes for glasses. Sometimes they've got 3 pairs of glasses. They might have 2 other pairs in their bag, so you've got to see them all. So yes, they've got sunglasses, but just document them. But they might have a $400 pair of sunglasses that if we don't take a record of it, we'll have to replace it. No hearing aids. You sure, love? No walking aids, so tick no, just go along with me here. No, any dentures? No. Clothing, just go yes, everyone's got clothing, hopefully. I haven't actually had a patient who actually came in naked yet. Surprisingly. You don't have to list all their clothing. Mobile phone you've done. Do you have a wallet or purse with you?
No, I'm not.
If they say yes, make sure you see it. Any jewellery? It's just the jewellery I can see, is it? So and this is hard because sometimes they have like 10 rings and it's really hard. So she's got gold jewellery on, but you don't write gold necklace. You just write YM, yellow metal necklace. So you can write, I would write
There's 2.
4 times YM earrings, 2 times YM necklace. You've just got to do what you can, and you can go into the other lines because often they're not being used. And you can also do any other piercings because they might have like a belly button piercing or something, so you can just ask them. Obviously, if it's in a personal place, you don't have to ask to see it. You'll just take their word for it. All right, everybody done their documentation. So by doing that, now we've conformed to one of the Fiona Stanley policies, and we get emails all the time saying, please document the property because we just pay thousands of dollars a month because someone gets home and they say, I had my phone, they took it off me and it didn't go with me to the ward and now I've lost it. And the ANUM's going to look for this and there's nothing written on the property status, so we really have no idea. The other thing is if they've got any cash with them or they want anything locked up in the patient trust, it's really easy to do. You just, like some people come in, they've got $500 in their wallet and you say, well, do you want us to lock that up for you? If they say yes, ring 52s, security will come down, they will take the money away, they'll count it out with you, they'll bring the book, they'll bring the bag to put it in and everything like that, and they'll just take it away, and then you don't have to worry about that anymore, and the patient doesn't have to worry, so it's a really good service that you can provide for them. Alright, now we get down to our substance screen. So I think this is probably about as far as we're going to get because substance screen is huge, and for that tiny little box, it's actually a really big issue. So first of all, it's good to know if your patient smokes because if they're a heavy smoker, they're going to start having cravings very soon. They're not going to be allowed to go out for a smoke for a long time. Like this patient's going to be here for 4 or 5 hours at least. Ask them if they're a smoker, and it's a bit awkward, especially when you're young and your patient's older. It's a bit awkward asking these questions, but I would just go up and say, "Are you a smoker, Emma?"
No. Oh, why are you asking me?
Yeah, exactly. They get defensive.
Why?
And sometimes it'll say, so say if she said yes, and I'll say, well, how many a day are you smoking at the moment? Pack a day, so 20 to 25. Do you want some nicotine replacement while you're here?
No, it doesn't work.
And they will say that. And so you can, it's good to, it does work, but they might not have tried it properly or tried it under the right supervision or the right conditions. So, well, you're going to be here you're probably going to have to be here for 4 or 5 hours, Emma, because they're going to want to have another blood test in a few hours, and you're really not going to be able to smoke here. So how about I give you some, like give you a puffer or something like that, and then you can have it, not have it, do whatever you like, but it just might help if you get some cravings.
No.
And they'll often say, oh, all right then. So then you, nurses can initiate nicotine replacement. So the nurse you're working with, just let them know that, this person's a heavy smoker, they might need nicotine replacement. There's all these forms you can fill in to screen them, but I don't think they're that easy to find these days. And that kind of gives you a guide as to, you can do the full thing, find out how much they smoke, and it'll recommend how much to give them. But I just tend to if they'll let me put a patch on them, I'll do a patch, and I'll get them an inhaler as well. So if you go to the med station and type in nicotine, it'll come up with all the options, and there's heaps of options we can give people. And one day I came on a night shift, and I was on triage, and there was this girl on ABA, and she'd been on ramp for 2 hours, and she'd come onto ABA, and she wasn't that old, but she had a personality disorder. She wasn't there for mental health, but I think she might have been at a query topic or something like that. And she had to stay for an ultrasound, and she really wanted to go out for a smoke, and she was a personality disorder on top of that, so she was really argumentative and manipulative and just driving everyone nuts. Nobody had offered her nicotine, or they might have, but she had said, no, it doesn't work. So by the time I came on, she was just coming around to ABA, and she was saying, my boyfriend's out there, he's got some smoke somewhere, I want to go and see him. And I think it's the beginning of COVID where they weren't allowed to have visitors and they couldn't come and go, and it was really strict. And so I went and got her a patch, because like I said, we can just get it out of the med station and give it. You don't have to ask the doctor, you can just do it. I went and got a patch, and I got her some of these, which are great. Have you seen these? So they're like a little, so they're like that. So they're kind of like a smoke, and it really gives them that benefit of being able to put it to their mouth and draw on it. It doesn't vape or anything, it's just an inhaler. But it comes with these cartridges, and you put the cartridge in for them, take that, put it somewhere safe with their name on it, because they might eat it or just trust some people. So I chucked a patch on her, and I gave her one of these, and she's walking up and down saying, it doesn't work, doesn't work, doesn't work. 10 minutes later, she's fast asleep on the bed, because she was so craving a cigarette. She'd been there for hours without being able to have one, and of course she's going to get agitated. So it's really worthwhile doing that screen, any sort of screen. Just ask them if they smoke. If they smoke a pack a day, they need nicotine replacement. It's really going to help them. And we also have these sprays. So this is like the latest technology in quitting. They spray it under the tongue. Apparently it's just brilliant for stopping all nicotine cravings, but they don't get the benefit of like pretending they're holding a smoke. So there's those. And now the other thing is alcohol. It's also really hard. So by giving them, so we've conformed to that standard. And now we have a really big drug and alcohol policy in ED. It's worth having a look. It's on the hub, and they have their own like section in the ED hub. And there's heaps of information there, and all withdrawals that you can imagine are covered there and how to deal with them. But the only thing you're really expected to do is, and it's part of like comprehensive care standard, and it's also recognising and responding to acute deterioration standard, because if someone's going to go into alcohol withdrawal, they can die, they can have seizures, they can be really sick. They can go into Wernicke's encephalopathy, where they have brain swelling and it can cause permanent brain damage. So it's important to pick up these patients, but they're usually so anyone drunk, basically, what would you do, or anyone who thinks got alcohol withdrawal problems, what would you do? Is there something you can initiate for them? You're thinking about your documentation?
There's the chart. It's not a
Yeah,
chart
the
on
alcohol
paper.
withdrawal chart. You can get one of those out for anybody. You don't have to ask anyone. They're in all the areas. So just, if you think anyone drunk, it's good to put one of those on. Put them on one of those, because if they're drunk, they're probably not going to go into alcohol withdrawal, but they could in a few hours. Anyone drunk, and that's got a good little screening tool, and that's the good thing about the paperwork. Like I said, the people that organise these safety systems for it, they put it all in the paperwork, because you've got a screen tool on there as well. So if you think, oh my God, what's the policy for that? What's the standard for that? How will I even know that? Just follow the form and it'll tell you everything to do. Most of our paperwork's like that. And when you're actually doing an alcohol withdrawal scale, there's a really good description of how to, how do I know if they're anxious? They're telling me they're this anxious, but they look more anxious than that. It really gives you a great guide. So it's a good example of how our safety systems filter down into our paperwork. So anyone who's drunk, I would put on one of those. If they're withdrawing already, you can usually tell when people are withdrawing because they look really unwell, and they've got a tremor usually, and they just get this look about them, don't they? I can spot one across the room because they're usually, their eyes are really wide, they're flushed, and they'll be kind of clammy, and you can just, and they just look terrified, because it would be a really awful thing to go through. Apparently it's disgusting. And they look scared because they've been there before. So anyone that kind of looks like that, or they've got a tremor, you can just say, are you much of a drinker? Emma, looks like you've got a bit of a shake up. Do you need some help with that?
Yeah.
Yeah, and sometimes they'll say they've been here before, and they'll say, yeah, I'm going to need some diazepam, I'm going to need something for that. And sometimes they'll just deny it, but you can ask the question, or on that, if you look at that substance screen, this is a bit dated because that audit said we don't use anymore, do we? So any patients who drink more than 6 standard drinks a day for 14 days prior to presentation are at risk of alcohol withdrawal. So that's it in a nutshell, really. That tells you how much they have to be drinking to be at risk. So if I say to Emma, how many standard drinks a day have you been having, Emma?
Bottle of wine every couple of hours.
Yeah, so that's right. So you can think about, a bottle of wine is, how many is that, 6 standard drinks? So if she's even drinking 1 bottle of wine, she could be at risk. But definitely if she says 2. Some people drink a lot, You have people that have been drinking a bottle of vodka a day, and sometimes, litre bottles even. It's unbelievable how much people can drink. So they're usually the really obvious ones. They're either very drunk, or they go into withdrawal before they even sober up. So they might come in like 0.2 on a BAL, but they can go into withdrawal long before their BAL's down to 0. So that's really important to recognise that and respond to it, because it's you can prevent alcohol withdrawal, and it's really easy. It's just following the form. It guides you as to how much diazepam to give, etc. Give me a minute. Just make the timers on here. Than I thought. So if we move on down the form, so if you can just go to that substance use, tick the yes. They do have, they do smoke cigarettes, and you can initial that. And then in your notes you could write offered nicotine replacement and what happened as an outcome of that conversation, and obviously it'll be on the med chart if you do give them some. And like I said, even if they say they don't want it, the other good thing about doing that is a really good just brief intervention for people, because some people might want to quit, they have no idea how to go about it. And they get some sort of nicotine replacement from us in hospital, and they take it home, and it actually works for them. And then they could go on to, ring the quit line or whatever, and formulate a plan to actually quit. So these little interventions that we do can make a really big difference to people's lives, not just their lives but to society, because we all pay for their poor health at the end of their life. They can be, the last 10 years of their life is going to be terrible. They're going to be sick, and they're going to be in and out of hospital, and you can really do your part as a community member by doing these little interventions. And not only the smoking one, but with the alcohol one. So if you do have patients that are drinkers, and if you're too uncomfortable to have a conversation with them about quitting and what they can do you know that we've got a drug and alcohol service here? We have like drug and alcohol nurses who are here 7 days a week in ED, and they work out the back, and they have a really, maybe you take them and show them just where all the resources are, because they have the desks out the back, and they have a lot of information there, and you can go and take brochures, and you can go and ask them anything. And we can refer our patients to them, and they'll come and see them like any day of the week. So it's not our expertise, but it is theirs, and they can guide them in the right direction. But if it's after hours and they're not there, because I think they're there till like 9 at night or something, various bit. You can always just give them some information on next step. Is there a next step card there somewhere? Oh, there is. So out the back where all that alcohol and drug information is, if you've got someone who's a real drinker and they might never have tried to give up. And a lot of people think about alcohol, giving up alcohol is AA is the only thing you can do, but there are so many other styles of helping people give up alcohol and minimise the harm to themselves if they are going to keep drinking. So it's not an all or nothing thing anymore. There's a lot of science about like the psychosocial model, which is different from the AA model. But this would be the first line of help that you can, the first place you can direct people is to next step. And if they say they're not interested, you just say, well, just pop a card in your bag and just, so they might get home from hospital and see this card and make that call, and that will refer them to all of the services that are available out in the community to help people with their substance abuse. So that's a really good thing, and that's part of your comprehensive care standard, and it's just a good thing to do for the person and for society generally. Alright, so we've done all those, so we'll tick the, we don't have the audit C anymore, but let's tick the yes. We've started an AWS on Emma, clearly a high risk patient, and initial it, because that's part of the documentation, isn't it? Okay, so you've all done your Braden scores, I guess. Have you done them on the wards and stuff? So you can fill that in for a well patient who's likely not going to have any pressure area risks. Okay, so in the meantime, doctors come in and he's charted some aspirin for me. So you're going to go to the med station and get the aspirin, and that's part of one of the systems that we have is the med stations that prevent so many errors. So giving the aspirin, we're identifying our patient, checking their allergies, and then you'll document that you gave it, won't you? And you know how we have the 6 rights of medication administration? Well, that's all laid out for you on a form as well, because you've got the right patient, you've got the right drug, you've got the right route, the right dose, the right time, the right documentation, so it's all there on a form, so we don't even have to think, oh, what are the 6 rights? If you just fill out your paperwork properly, you are doing doing the 6 rights and you're conforming to the medication safety standard. Alright, so you've done, do you want to go back, have you signed your medication that you've given it? Given by, what time? Okay, you happy you've done the 6 rights? No, everyone happy with that? Alright, if you could go on and do your braiding. Something I probably don't have to help you with. Have you done braidings on the ward and everything? Yeah. Alright, so I don't think we're going to have time to do the fall and cognitive risk screen, but I'm just going to recap quickly what we've done. So they're both part of the comprehensive care standard. Alright, well thank you for coming. So we just quickly recap the framework for nursing practice. We talked about the National Safety and Quality Health Standards again and how they relate to what we do on the floor, and I've just tried to link everything we do to the paperwork we fill in, and how by just doing your documentation properly you are going to be fulfilling all the expectations they have of you as a nurse under the standards. And we practice our scenario, and if you wouldn't mind, I'll just get you to do a quick evaluation again, like you put me on Friday. Thank you, that's part of my course material that I have to get signed off. Now I'll get all those up and I'll shred them, so I don't want anyone thinking that's me.
Thank you.
Oh, I didn't get the learner profiles done. Oh yeah, I didn't give you, didn't have to do this. Oh, sorry guys, I forgot to ask you to do that learner profile again. You don't really have to do any comments. If you just put your name on it, tick those boxes, that would be great. And they already underrate themselves, because it says, how do you rate your reading and writing and your mathematical skills? And they all rate good instead of high, but to be at your level of education, you would have high reading and writing skills. Otherwise you just wouldn't be able to get through it. It's really great. Thank you, I appreciate your time everyone.